rounds for June 5th. As usual, we will start with our land acknowledgement. So Ottawa is built on unceded Algonquin Anishinaabe territory. The peoples of the Algonquin Anishinaabe Nation have lived on this territory for millennia, and we honor them and this land. Their culture and presence have nurtured and continue to nurture the land. CHEO also honors all First Nations, Inuit, and Métis peoples and their valuable past, present, and future contributions to this land. Today, we are very excited to have an amazing group of PGY3 residents presenting to us today. Dr. Marissa Aycan, Dr. Jeffrey Doe, Dr. Brian Earl, and Dr. Regan Mah are a group of third-year pediatric residents at CHEO who are passionate about promoting patient-centered care and improving patient experience at CHEO. They're going to present to us today about, they're going to review patient and parental access to personal health information. And it's very timely because we are actually currently in a working group to look at result release together with Sick Kids. So many people are very excited for this talk, and we look forward to it. So I'll hand it over to our third year resident group.
So thank you so much for the great introduction. So my name is Regan. I'm a PGY3 resident. I'm very honored to be working with my wonderful colleagues on presenting on this topic. So helpful or harmful review of patient and parental access to PHI. We don't have any conflict of interest to disclose. And I'm just gonna wait for our slide to move. And these are some of the objectives that we'll talk about. And a review, we'll first go through some background, followed by a review of literature, some case discussion, future direction, and concluding at the end. So personal health records refers to a collection of an individual's medical records maintained by the individual themselves or caregiver. PHI could be physical, or it has becoming increasingly common to be electronic. It includes all self-report and self-recorded health data, but also medical records such as the patient's past and current medical history, historical and ongoing medication, immunization status, notes such as their consultation report, admission notes, and investigations such as lab and imaging results. The goal of PHI is to allow patients to keep their health records readily available for themselves and anyone involved in their care. The three important elements that are therefore crucial in PHI includes their accessibility, privacy and security, and integrity and accuracy. And PHI therefore becomes crucial in assisting us in providing tailored medical care. And some of the benefits that PHI brings include clinical, research, and legal aspects. For clinical, PHI provides the snapshots of the individual's health that allow patients' information to be available during times of emergency and when patient is traveling. With its availability, PHI can therefore promote better healthcare with management of information between care providers and coordination of cares. It allows us to track patients' health, seeing progression of their illness management and health trajectory. It allows us to identify success and failures in the delivery of care and the underlying reasons for them. Another important aspect is that it improves patients' engagement. A big component of what patients do to their health happens outside of clinical setting. And when patients can track their health over time and have information and tools to manage their health, they can become more engaged in their care. Similarly, it is helpful for caregivers such as parents caring for children and elderly family members to manage their care with the help of this information. With a lot of PHI being on electronic system, it provides us a rich source of patient-centered data to support clinical research and trial that answers a broad spectrum of clinical questions, whether that be assessing quality control projects that we conduct in the hospitals, comparing effectiveness of treatment, and studying various aspects of this disease. Finally, PHI can reduce administrative costs by allowing patients with easy access to electronic prescription, appointment scheduling, and acting as a direct portal of communication between patient and provider care. And from a legal perspective, it serves as a source of information during legal trial and assisting with a reimbursement process for patients. One important Canadian legal case surrounding PHI is McIlroy versus McDonald in 1992. Dr. McIlroy is a doctor in New Brunswick, and Mrs. McDonald was her patient. Previously, Mrs. McDonald was treated by other physicians for numbers of years, and on consultation with Dr. McIllery, she advised Mrs. McDonald to stop taking thyroid-related medication that was previously prescribed by other physicians. This advice then prompted Mrs. McDonald to become concerned over her medical care from the past and request for content of her complete medical files. Dr. McIllery delivered copies of all her notes, memoratas, and report that she prepared herself, but refused to produce copies of consultants' report that she has received from other physicians, stating that they were properties of those physicians and it would therefore be unethical to release. She suggested Mrs. McDonald to contact these other physicians to release their records, and this dispute themselves lead to the case. Ultimately, the ruling of this case is that the patient is entitled to examine all information of their medical records, which physicians consider for their medical advice, including those prepared by other doctors. Although the doctor is the owner of the record, but information is held based on the trust that physicians would use them for the patient's benefit. The court emphasized that the doctors have duties to act with utmost faith and loyalty, to hold information received from or about a patient in confidence, and to make proper disclosure of information to patient. Therefore, it is also the obligations of the doctors to grant access to information used in administering treatment because patient has a continuing interest in their care. And by granting access, it also allows for proper functioning of doctors-patient relationship. However, the court also ruled that the access of medical care is not absolute if the physician reasonably believes that it is not in the patient's best interest to inspect the medical records. But why does this case matter? Well, this case also highlights the idea that physicians owning a patient's record is a paternalistic perspective. Although this case has granted the patient's access to the PHI and set precedents for it, it does make us think for a moment whether we have really evolved from this paternalistic mindset of the past. Currently, there is the Personal Health Information Protection Act, or PHAPA, which is an Ontario legislation in 2004 that provides rules in regards to the collection, use, and disclosures of health information by health information custodians. So health information custodians could be your doctors, clinics, or hospital. And patient has the right to access for correction of these, can have the rights to request for access or correction of the health records. Patient can do that through the request to access personal health information form, and from there, it would take 30 to 60 days to fulfill the request. The main obligation under PHAPA is to provide guidance to health information. So having us required to obtain consent to collect, use, or disclose PHI to ensure there's proper security over them, to ensure that the PHI themselves are accurate, and to only collect, use, disclose as much PHI as necessary. To also provide individuals with the ability to access and correct the PHI. There are limitations, though, toward the access to PHI. Oh, sorry, to the next slide. And these would include health records that are subjected to legal privilege, such as solicitor and client confidentiality, if there are serious harm to the patient or another person, if the health records themselves is part of an inspection, investigation, or similar process, or if there is another law that prohibits or discloses health information. Another important legislation that we should talk about is the 21st Century from the United States. It is a legislature first introduced in December 2016 that emphasized patient engagement. It provides guidance on how to review data related to drugs and device and the process to facilitate the collection and review of patient-focused data. So it would cover various areas going from FDA drug approval process to informed consent, and more importantly, to electronic health information, health records and information blocking. So electronic health record and information blocking is the idea that information blocking that interferes or preventing access to electronic health record. There was a specific legislation on April 5th, 2021, where there's a requirement where a patient must be able to access information in their EHR without delay. It focused on the interoperability and prohibit information blocking. And this introduced the idea of open notes, where all notes must be shared with patients. Open notes provides patients with basically transparency to healthcare via convenience access to information in their EHI. And this rule basically applies to the healthcare provider, health information network, to IT. Although there are some exceptions to these rules, including preventing harm, so provider must provide a reasonable expectation that with the exception if there is harm to the patient or another person. There is also a privacy exception that protects an individual's privacy, security if there's concern with security over the EHI, invisibility and an invisibility exception as well. Currently, at CHEO themselves, we have MyChart, which is a secure online patient portals that connect patients to their part of the electronic health record. From the picture themselves, you can see that it can provide a summary of the patient's health issues. It can provide lab results, their growth chart, their electronic appointments, and so on. Another interesting cool function of CHEO MyChart is the fact that it can provide a two-way communication between patient and their provider cares team. It also allows for electronic check-in. It allows for us to send records of their healthcare records to other people as well. And then this concludes my part of the presentation. I will pass it on then.
Awesome. Thanks, Regan. So now we're going to talk a little bit about some of the literature that exists about pediatric access to personal health information. So as we mentioned, there are really many different ways to be able to access personal health information. What we're going to focus on mainly through this talk is really on those patient portals, which refers to the electronic systems, which are either integrated into the electronic medical record or are separate from that give patients direct access to a variety of their information. When we talk about open notes, that specifically refers to access to free text notes by clinicians and other healthcare providers and is encompassed under the scope of patient portals in general. So since the advent of these patient portals, there's been a significant amount of interest into understanding how patients and providers feel about these. So on the next few slides, we're going to go through a summary of 3 review articles that kind of talk about this topic. So who's been studied so far in the literature? Many studies have looked at how children and teens, parents, healthcare providers, as well as other stakeholders have interacted with patient portals. So the figure on the right of the screen there is from one of the systematic reviews, which summarizes a number of the studies that looked at each of those respective groups, as well as the country from which they were studied. So as you can see, the majority of those sections, the green, purple, and blue portions of the chart, are looking at kids and teens, parents, and healthcare providers. And the vast majority of these studies were conducted in the US with really limited Canadian data. So here we're looking at a figure which summarizes what exactly has been looked at in the literature. So the majority of studies have looked at really portal use in general, with some studies focusing on how the user experiences differed before implementation of an electronic health record or afterwards. But many studies also just focused on the experiences overall. So we know that these portals are readily available, but do patients and families actually use them? So here's a summary table showing the use of parents on the top row and children and adolescents on the bottom row of these patient portals. From collation of multiple studies, the general theme emerges where parents tend to often use the portals in early childhood, and this sort of weans off by adolescent time. And they use it really mostly to look at appointments and test results. Interestingly, when you look at some of the studies, there was less use among minority groups, so non-white minority groups. When we look at teens in general, really the teenagers and early adolescents were much more likely to share the notes with their parents, as you might expect. And that use of their patient portals actually increased as they became older and approached transition to adult care. So what have their experiences been like in general? So on this slide, what we're looking at is a summary of the expectations of providers, children and adolescents, parents, and other stakeholders on the left-hand side. And on the right-hand side is the experiences. And so that's split by the different populations studied. The green text represents overall positive aspects, and the red text is things that were reported as challenges or barriers. In the middle are the themes that overlap, where the expectations were similar to the experiences. So in general, most people found that patient portals helped with transitions to adult care, remembering details from appointments, and gave a sense of empowerment in managing their care. Some of the main challenges included concerns around understanding the information as well as confidentiality. So in summary, overall, parents felt like some of the benefits were improved communication with their healthcare team. They were better able to have timely access to information. And as a result of that, they could better understand their child's illness and felt a bit more empowered to advocate for their child. Of those that participated in Open Notes programs, there was a perception of improved quality of care and safety. Some of the main challenges that were highlighted were really around the technical jargon used in notes that were difficult to understand, information overload, and potential discrepancies between medical records. Some of the general concerns providers had were on confidentiality issues, which we'll talk about a little bit later. So now we're just going to dive a little bit deeper into some specific examples in the variety of settings where you may see this in the outpatient, which I think here at CHEO we may be a bit more familiar with, and then inpatient and ICU settings. So here's a study that highlights one of the outpatient settings. It was done at the Cincinnati Children's Hospital, and it looked at parental perspectives of using a patient portal for kids with chronic medical conditions, including cystic fibrosis, type 1 diabetes, as well as JIA. So what they did was they sent out surveys and conducted interviews with parents on the experiences of using that patient portal. So this figure shows the results of surveys of parents on using the portal and accessing information. And so overall, what parents found is that the portal was useful, accurate, and timely, as well as pretty easy to use and learn. The main concerns that parents had were regarding confidentiality, although this was a relatively small proportion of parents. Of note, 12% reported that they sometimes saw information on the chart that frightened them or that they would have preferred to see directly from a provider. This included things like abnormal results or investigations, as well as diagnoses mentioned in the chart. Many parents felt that having access to their notes provided an improved understanding and ability to manage the child's chronic medical condition. It helped them to make healthcare decisions and communicate effectively with the provider. And many reported improved relationships with their healthcare provider as a result of having access to their notes. So based on this study, there's a few thoughts that arise to consider. Caring for a kid with a chronic medical condition can often be stressful and disruptive to parents and families, and a lack of information and communication with the team can exacerbate this stress. So patient portals can be considered one tool that could potentially help families in order to lessen the burden of caring for a child with a chronic medical condition.
So now I'm going to build off of some of the content that Jeff has already spoken about by specifically discussing the experiences that caregivers have had interacting with portals and provider notes in the inpatient pediatric setting. In order to do this, I'm going to highlight one of the larger studies that's been conducted, which was completed at a medium-sized US Children's Hospital, where the authors recruited English-speaking parents of children who were less than 12 years old who had been admitted to their inpatient pediatrics unit. And at this particular hospital, they used an Epic EMR, which is similar to ours here at CHEO. And parents were provided with something called MyChart Bedside, which is an inpatient portal that included up-to-date results, vital signs, and a tool to communicate with their inpatient care team. And it also provided information on the CTU environment and an orientation to that, as well as a debriefer on inpatient rounds and some other learning resources that parents could make available to them. And I want to highlight that in this particular study, results that were made available to families were only made available following discussions with the team during the daytime rounds. And data in this study was collected using semi-structured interviews. So the authors in this study identified 5 major takeaways. The first of which were that parents found that having access to an inpatient portal allowed them to better monitor their child's progress throughout the hospital stay. And they found this was feasible by looking at vital sign and lab trajectories, which gave them a better overall sense of their child's improvement. They also found that, or caregivers found, an increased sense of control and a reduced reliance on staff. And they felt that that translated to a sense of empowerment. They also found that having increased access to information translated to a better experience on inpatient rounds, ultimately facilitating communication with their medical team. And parents also found it allowed them to validate information within their child's medical record. such as confirming the accuracy of their child's medical list and making sure it aligned with what they provided their child at home. And lastly, parents also found that the portal prompted their memory for questions that they had thought of previously that they wanted to pose to the medical team, and ultimately made for easier discussion with the care team. So overall, caregivers remarked that they had a really positive experience interacting with these portals in the inpatient setting, and that principally it allowed them to play a more active role in their child's care and not simply feel like a bystander. And moreover, the vast majority of parents in this study remarked that they would want to have access to their child's inpatient portal again in the future, with many remarking that they would like to have access to their child's inpatient progress notes during future hospitalizations, as parents felt like this could further improve their understanding of their child's medical condition and plan. And they would also be particularly beneficial during those times when parents cannot be present during inpatient rounds. So since the publication of this article, many further studies have been conducted that have looked specifically at that question of how do caregivers interact with inpatient progress notes and what's the experience of that. So similar to the study I just mentioned, these were also conducted in medium to large size US children's hospitals with English-speaking parents whose children were less than 12. And most of these parents reported or self-reported limited health literacy, so about 50% or more. And in these studies, I just want to note they were also interacting with the MyChart bedside portal, but now they had access to notes. But notes were only made available to parents after staff physician approval. And parents were notified that this would occur following the daytime rounds, but before the next day of rounds, so that they had the opportunity to think about questions for the team. And similar to the past study, the data was collected through interviews as well as surveys. And what you'll notice here is that this is a composite of some of the benefits that these studies had ascertained. It's similar to what Jeff had spoken about before and similar to the experience of caregivers who interacted with inpatient portals. What I specifically want to highlight is that parents found that having access to inpatient progress notes further increased their knowledge of their child's medical condition, as well as the indications for their ongoing hospital stay. And they found it further improved their ability to communicate by not only giving them an understanding of their child's condition, but providing them with the right words to describe their child's condition to not only the medical team, but also to the child's school. And something that's interesting was parents remarked that it made it easier for them to hand over care to other family members who might be looking after the child, because they felt like it provided them a better way of explaining what was going on. And parents also found that it was easier for them to communicate with their child about the reasons why they were in hospital, and then as part of that to offer their child reassurance. And similarly, parents and caregivers found that having access to an inpatient portal, it increased their sense of empowerment and autonomy, and it also gave them a greater sense of confidence and trust in their care team. So these benefits were accompanied by some challenges, as we might expect. So one of those that we'll discuss further in the presentation is this idea of preemptive disclosure. So some parents did find out or did comment that they found out about their child's diagnosis or results before having a discussion with their child's care team, which led to some distress in certain situations. And some caregivers identified inaccuracies or outdated information within notes. And some also found that documentation increased their confusion and required them to rely on online information for clarification, while others found that having a long list of differential diagnoses in their child's notes could increase their sense of concern about their child's condition. Now, these providers also offered opportunities for improvement. They suggested setting expectations for parents at the beginning of the hospital stay, explaining that notes are principally used for physician communication, and also the option of providing caregivers with a sample note so they could get a sense of what to expect when looking at these inpatient notes during the stay. There was also a strong consensus for ensuring that notes are not released prior to discussions with the medical team during rounds, but that they're still available before the next day's rounds so that parents have the time to ask appropriate questions. Caregivers also provided suggestions about developing more parent-friendly note templates that could be implemented by removing headings such as subjective or changing that for terms such as updates from overnight, creating collapsible components of the note to prevent that information overload that some parents tend to experience, and then also incorporating technology and educational resources within the notes so that when parents hover over medical terms that were unfamiliar to them, they could get a definition for that and potentially to reduce medical jargon that's associated. And now I'm going to hand it off to Jeff, who's going to speak a little bit more about the experience specifically in an intensive care environment.
Awesome. Thanks, Brian. So we talked a little bit about kids in both the outpatient setting as well as the general inpatient wards. So now we're going to shift gears a little bit and talk about kids in critical care. So this is a recent study just published a couple of months ago in Pediatrics, which looked at the experiences of parents whose child was admitted to either the PICU or the cardiac ICU. And so they conducted interviews and looked at parents' experiences with open notes in the ICU setting. So overall, the results showed similar benefits as noted in outpatients and inpatients regarding parental perception of improved coordination of care, communication of information, as well as ability to advocate for their child. The ICU environment, however, had some different challenges that are important to highlight. So children admitted to the ICU have inherent medical complexity and acuity, which can make it more challenging to navigate as a parent. There's a heightened stress and emotional toll in an unfamiliar environment with intense emotions and uncertainties. So despite these unique challenges, it was interesting to note that parents still found that having access to their child's record and notes helped them to actually better cope with the ICU admission and help them to navigate a new parental role. So the idea of this parental role is that parents are often the primary caregiver for their child with the principal goal of caring for them and advocating for their health. When they're admitted to hospital, in particular in the ICU environment, this role really shifts towards the healthcare team, which leaves parents a bit uncertain of how to continue to contribute to their child's health. So parents actually, interestingly, reported that access to their notes helped them to feel like they were making a contribution to realign themselves within that parental role, as they could better understand the day-to-day changes in their child's care and medical condition, and as a result, could be more prepared for rounds and discussions with providers. So in general, parents in the inpatient setting, both whether that's general pediatrics or in the acute care setting, felt that the benefits of access to notes outweighed the possible risks, and most indicated that they would want access in a future admission to their child's notes. Access to clinician notes actually helped to counteract parental uncertainty, reduce parental disempowerment, and improve relationships with the healthcare team. This was in spite of some of the challenges regarding accessibility in terms of health literacy and understanding of note content.
So now we just want to highlight what are the opinions of providers or what are their perspectives since the availability of open notes and inpatient or outpatient portals. And it's interesting that some of the initial studies on this topic demonstrated that providers were concerned that parents would have limited satisfaction with access to these interfaces and obtain only a modest benefit from using them. Often citing the definite potential for increased confusion that providers believed might happen when parents and caregivers had access to these portals or notes. But it's really interesting that this skepticism that was initially held by physicians has really not been realized by parents and caregivers. That's demonstrated in the figure on this slide here, where despite physician skepticism, so most greatly shown by interns actually or residents, was really not held by parents who found they drew great benefit from accessing these portals and notes, which I think we've alluded to throughout the presentation so far. When we look at specific studies that look at the benefits and challenges physicians identified, we note that a lot of the benefits that physicians found were very similar to what caregivers found as well. Specifically, physicians felt that having access to portals and notes increased transparency for families and allowed them to more closely participate in their child's care. While others felt like it could actually improve their documentation style and also contribute to patient safety by having caregivers weigh in on inaccuracies within the medical chart. Now, some physicians did identify challenges, and they were worried that caregivers having access to the notes could reduce documentation of sensitive information, as well as potentially increase workload. But it's interesting to note that in the pediatric studies that exist, providers in those studies only 30% of the time reported adjusting their documentation style when parents had access, and only 15% reported having a greater workload. And when we look at studies in the outpatient context, specifically amongst adult providers, the majority have actually found their workload has reduced as patients have had access to notes because they find that patients are better able to answer their questions using these notes and rely less on their physicians for answers. Now, there is still this concern for potential of these portals to invoke caregiver anxiety, and that's mostly related to the early release of results, which is something that Marissa is going to speak to later. Now, there are areas for optimization that have come up in a lot of these studies, the first of which is the focus of physicians on objective documentation, which I know is something that was discussed in last week's grand rounds. So for example, trying to document a patient's BMI in their note or in their chart, rather than describing a patient as being obese, to ensure our records are more patient-centered, and also trying to ensure that our documentation of sensitive information actually aligns with the discussions that we have with patients. And this really follows the doctrine that we shouldn't be documenting information in a patient's chart that we have not discussed with them first. And there's good evidence that shows when we document in this way that we also improve patient-centered care and improve patient trust in their physicians. The other recommendations were surrounding the use of technology to mitigate workload, which is another topic we'll speak to a bit later. So just to wrap up this section, we wanted to focus on whether there are any issues or barriers to access for these patient portals, since there has been benefit that's been ascertained. And unfortunately, what the literature does tell us is that individuals who self-identify from vulnerable groups tend to interact with both inpatient and outpatient portals less frequently. And this has been shown to be related to a combination of factors. One of those being that there is no or limited portal interfaces in the patient's preferred language. There's also the possibility of individuals having reduced overall or specifically digital literacy. It's also the possibility that individuals from lower SEFS groups lack access to the technology to use these systems. And interestingly is the observation that individuals from vulnerable groups actually report having less overall awareness of the existence of these portals in the first place. So the literature does offer us some suggestions and ways to improve. The first is incorporating technology, and ways in which we can do that are providing access to Wi-Fi and portal-enabled devices to our patients. This is obviously something more feasible in an inpatient setting, as well as trying to develop automated conversion of notes and data into multiple languages to make it more accessible. And from the perspective of education, is focusing on training patients in basic digital literacy skills so they can interact with these systems more adequately or more in a more feasible way. And also trying to educate physicians on the importance of encouraging caregivers to read notes and offer feedback, and providing patients education on what content is available in notes and how this can be used to facilitate conversations with their providers. And the last piece is a more novel system that's been implemented in the States as well, which is something called Our Notes, which is a system where patients actually have the opportunity to contribute to their own medical record. So specifically the HPI and subjective components, so that those aspects of the note more align with the patient's experience and are not just a physician's interpretation of someone's own medical experiences. So with that, I'm just going to hand it over to Marissa, who's going to talk about some specific concerns related to adolescents.
All right. So I just wanted to talk a little bit about specifically adolescents, especially related to the personal health record, because this population often has parents and caregivers who are really important members of their healthcare team, being part of their health record some of the time, and what issues could possibly arise from that. So just looking at some perspectives about adolescent access to open notes, which is coming out of the states where this is happening. There are many advantages that were felt to happen. So it's helping adolescents remember, review, and reinforce information in the visit. And it helps them to gain knowledge about their health, which is especially important in their transition from pediatric to adult care. And it increases their engagement and agency in the healthcare, which are things that the adolescents themselves had noticed when they were reviewed with. But some of the concerns that they brought up specifically were about possible breaches of confidentiality, especially with sensitive health information, and that there's the possibility that notes could cause negative emotions or feeling judged by their provider, specifically with the use of language. And this was also felt to be an important note from the parental perspective in having their teen have access to their own notes. From a physician side, the most significant concern were twofold. So one of them was, how do we appropriately address confidentiality in this sensitive group of patients, and that there could potentially be an increase in physician workload to make these notes accessible to a teenage population with even potentially different health literacy than their parents, and then having this be a decreased usefulness in the note as a communication tool between providers if you're not able to say all of the information that you might want to, depending on what you're able to disclose in a note that's going to be shared with a parent. I wanted to just bring that together a little bit with a case about documenting sensitive information. So this is an example of a 16-year-old girl who is presenting with moderate asthma to their pediatrician for their scheduled appointment with their mom. And after addressing the patient's asthma, as we all do, we ask the mom to step out of the room so we can have a confidential discussion with the adolescent. And they disclose that they've recently become sexually active with a male partner and they're interested in initiating birth control. They state that their mom is unaware of their sexual activity and they prefer not to share that with their parents at this time. And so after discussing birth control options, they decide that an oral contraceptive pill would be an appropriate choice for them. The adolescent patient's mom is brought back into the room and the visit ends after some additional recommendations about the asthma management. And as they leave, the mom comments that they're looking forward to seeing the note through the portal so that they can share these recommendations with their partner and with the school nurse for their asthma management. So I just wanted to highlight this because it applies to any sensitive information disclosed by an adolescent. We discuss confidentiality really anytime we're speaking to an adolescent alone, and their trust is so important to having a therapeutic relationship. And we discuss that, we're not going to breach confidentiality. And so now that we have more open access to a group, what do we do about it? And especially in this case, when a parent might be already expecting a note because they have access to their EMR, what are our options in trying to keep this confidential? So, some of these things have been, you can make a separate private note that would outline that section of the conversation, but people have a really significant note burden already. Could you share only pieces of the health information with different groups and have confidential sections, but it brings opportunity for error? Or if you know that there's going to be a visit without the parent, could you mark that as confidential? And if they're already expecting a note, how do you not put it there and then bring about concerns from that parent? This also goes beyond notes because if we think about, for example, in this case with an oral contraceptive pill, it's going to be on our medication list. Who is going to pick up the medication? Are they on the insurance? Which is, beyond the scope of this talk, but what gets pulled into further notes like auto-population of medication lists that might not always be confidential, and that in hiding some medications or hiding part of the medical record from a parent or keeping it confidential could lead to possible safety issues if you're dissociating information and if it's not easily accessible to other providers who are going to need to provide care. So just some thoughts about how might people document. So you could not let the parent see the note, and that protects the adolescent, but it's preventing the parent from accessing medical information and sharing it with other people. And parents are often very important parts of the adolescent medical team. This also might raise suspicion from a parent if they were already expecting a note, because the times that you can change the access easily to access to notes, for example, in our My Chart, which I'll talk about in a little bit, are at certain ages. You could flag sensitive information, but this could be prone to mistakes. And if you forget to do it, it could have significant consequences to your trust between you and your patient. And making two separate notes is probably safer from an unintentional sharing perspective, but it compartmentalizes your medical record and it could make information more difficult to find for you or for other people who might need to see it. Either way, I think that the most important thing is trying to ensure your patient trusts and avoid confusion. So you need to communicate effectively, especially with all patients, but especially with our teen patients in this process and if it's occurring. So helping them understand what you're going to write, how it will work, which also can help the teen engage in their management of their care. And they might have a good reason to keep part of their health record separate from their family, but it's important to share healthcare information with trusted people. So our healthcare information overall is just needing to be motivated most centrally by our patient in front of us and how it can best serve their needs, which means talking to them about these choices, and about how we're going to effectively communicate with them and their family. A second point that I wanted to bring up is our access to results and the time of access to results. So this is an example that's happened before, where a child had an outpatient MRI and there were findings concerning for malignancy on the report that was done as an outpatient. And because parents, even after a time delay, which is what we have at CHEO, parent can read the imaging report prior to being called by a provider about that time. And so they are able to see, the differential diagnosis, the concerns that are on that report. And this could be perhaps before they've had a chance to talk about it or to discuss it with any provider. There's some potential benefits of this. So if there's a concerning result found, they can seek emergency care and they can bring it up or call, and so things might not get missed. And there's increased transparency, but there's certainly a potential risk of not having an ability to provide support or information to a patient at the time of diagnosis, or to establish a plan of care. There's no guidelines for appropriate delays in posting information currently in Canada, but trying to allow time for a provider to answer questions appropriately and have some access to that information is certainly a concern and is important to providers when we look at the literature. There is a study out of the United States, all from adults and as an outpatient, but it was quite large. So it was multi-center and more than 8,000 respondents. And actually 95% of respondents preferred to receive results immediately through the portal. And this included also 95% of respondents who received abnormal results. So whether or not the result was normal or abnormal, patients preferred to see it, even if that meant that they saw it before their provider or that they had a chance to speak about this. They did show that, 16.5% reported that viewing these abnormal results definitely increased worry, but despite their worry, they still preferred to have their access. Just some considerations about that is that, patients do have a right, as we've seen through multiple legislation, they have a right to know the contents of their record, and there's potential harm due to timing of result availability without these opportunities to interpret and contextualize results. It can lead to significant stress and emotional distress if you learn of an abnormal result. And it's part of our work to make sure that we can educate on our conditions and provide guidance for treatment. But there's also a potential, one that results are upsetting, but also that patients could misinterpret results. And a small example of this is a patient who has anemia on a CBC and could self-treat or self-diagnose before they get seen, which could cause, in this example, probably a small issue, say if they're taking iron and they get gastric upset afterwards, but something that could possibly have been avoided if you had spoken to your healthcare provider. And just to highlight also that the nature of results and category of results are important. So things like imaging, pathology, HIV testing, things like that might be more sensitive and might warrant slightly different care than things like lab results that were done on a routine basis. And then I just wanted to talk about what we're currently doing at CHEO and what possible future directions might look like. So right now, what happens at CHEO is that you can view lots of things in my chart, like Regan was talking about. So your health issues, most of your lab and imaging results, select letters and notes, but definitely not open access, like we've been talking about what's happening in the States right now. And we can send our two-way secure communication about the patient and the family to the CHEO team and complete questionnaires and answer questions between providers. And especially in the outpatient setting, there's lots of communication between clinics and patients to help the burden of care and ensure that patients are taken care of appropriately. Our access to results right now, so this is the release of our test results to my chart. So normal and abnormal results from the lab are 1 day, where medical imaging right now is 7 business days, and same with pathology at this time. Any sensitive results, so those are things like sexually transmitted infection testing, or genetic results, those are not released onto our MyChart unless they're specifically asked for. And then just quickly to say that we handle adolescent access with proxy-enabled accounts for young children, and there's a cutoff automatically at age 12. And then again, on later teenage years, in order to make sure that the teen is still okay with having their parent have access to their MyChart, and the parent will automatically get locked out unless they have specific allowance to do so. And if they can't provide consent due to capacity, they have to complete a release restriction at the discretion of the medical team as well. And then this we thought was interesting to bring up, and probably a few years out from any time where it could be used, but whether there's any benefit to using artificial intelligence and note sharing. Part of it was to try to address some of the concerns about note sharing and the increased clinical workload, and trying to convey results specifically for each family depending on health literacy. And so a possible solution is using a generative AI to try to train notes to be written specifically for the patients as a summary of their health record, which actually in the data shows that it might be more consistently sensitive than the provider notes that are currently being written, and that it can write to specific health literacy. But right now, they haven't trained AIs in the data set of health record. And it's important to note that any biases that are existent in our health record would also be taught into that artificial intelligence. And so there's a lack of consistency in response as well. So definitely something to think about in the future, something that's very interesting, but not something that's being used right now. And then just to say that, from what we've seen, the data suggests certainly that patients and parents having access to their personal health records is very beneficial for both knowledge translation and trust in the care team across multiple contexts in the pediatric population specifically. The concerns are real, including appropriate disclosure and explanation of information, and then the burden of writing notes at an appropriate level, while still being effective to the healthcare team and still being effective between providers. And ensuring appropriate confidentiality for adolescent patients is important, and it's challenging to ensure that the health record doesn't accidentally convey information that is not meant to be shared between different people who have access. But overall, that family-centered care really does appear to be enhanced in other healthcare systems who have open access to health information. And I know that at CHEO right now, we're certainly in the outpatient setting having more and more access to notes and results and using the MyChart portal effectively, and certainly something that could be looked at in the future for multiple settings and across our domains. These are just some of our references, but thank you so much for listening to us. We're happy to chat about any questions that people might have.
Awesome. Thank you so much for that excellent review. I'm sure there will be lots of questions. I will start off with a question of, you talked about, on inpatient patients, families having access and be able to answer more questions. Did anyone look at, the amount of questions that were asked? I'm trying to word this totally appropriately. How many questions the families then had on rounds after they've, had their notes and Googled everything? And I'll give an example. When patients get MRI results for brain tumor patients, radiology lists every, there's a small little this. And so we spend a lot of time in our clinic going through every single line of that MRI report. Whereas if the parents didn't have the report and were just viewing the screen, we would show them the important, not the things that not that radiology lists unimportant things, but some things are not of any concerns, but parents see the word and they're concerned. So did they spend a lot more time on rounds? Did they look at that, dealing with questions about, things that they read that they didn't, that you wouldn't have normally discussed on rounds? The short form of the question.
I could try taking a stab at answering that. In the studies that I looked at, Dr. Johnson, I didn't see that any had looked at timing of rounds, or like whether it prolonged the discussions. I think what's interesting though is in that slide I presented that had the figure of physician satisfaction with open access compared to patient or parent access to those notes. Like interns and attendings found it was less favorable, and one of actually the lines in that figure is I think one of them is parents being better prepared for rounds, and the attendings and interns felt like there was less favorable, that parents were less prepared for rounds, but parents had the impression that they were more prepared for rounds. So I don't know if that translates at all to longer discussions that happened or if the rounds were less streamlined, but I think, yeah, interesting question that maybe has not been well explored yet.
Great. I guess another question, like if you could, obviously I'm an oncologist, so we have concerns about our families getting, lab results that show that they've got blasts now and they've relapsed their leukemia, or MRI showing that they've relapsed their tumor, and so we always try to get, we will always get to the family before the results are released. But if they're immediately released, we have concern. And I know you talked a bit about it, like 30% of people were not happy about having results, and that's adults. Did you see any pediatric data on concern about getting notes about very terrible, very bad results, but immediate release, and the team isn't there to support them?
Yeah, in the outpatient setting, although it was more in kids with like chronic medical conditions, not specifically oncology, there were some parents, like about 12%, that said that they saw stuff that frightened them, but they didn't actually feel like that detracted as much from their overall experience of still having access to the notes. So some of the like benefits of being able to communicate a bit better were outweighed by potentially seeing something a bit fearful. But it'd be interesting to know. And then it's different in sort of like the inpatient ICU perspective, where there's a team kind of readily available at all times to kind of answer some of those questions. So it'd be interesting to look at specifically in the outpatient.
There's also not in the States where it's like open access, immediate release, but some of studies out of Europe that have like immediate release for normal results, and anything abnormal needs to be like checked by the physician before it can get released to my chart, especially with more sensitive information. And so I wonder if kind of utilizing that model and saying, okay, for things like imaging, or when we're specifically worried about something like in oncology clinic, for example, perhaps it's not immediate release, and after you've connected with the family, then you can release that information. And there's also some studies looking at whether it's possible as our electronic medical records get more and more improved, if families can opt in versus opt out of immediate release, depending on their comfort. And obviously people are not expecting devastating results, but if there's informed consent to having that immediate release, perhaps that could also, you could use some of the parents' own knowing about themselves and their anxiety about whether they'd like to see those results or not.
Great. I'll just highlight, because I can't see if hands are up. So people, if you want to speak, just turn your camera on. Just to highlight so people are aware, the Pocket Health is offered by our radiology department, and that gives immediate release for radiology reports. So my chart, it's a 7-day delay, but Pocket Health, it's an immediate. And I don't know that everyone is aware of that when they order imaging. And certainly we've had challenges in oncology where we're getting the relapse at the exact same time as the parents, and it's created some challenges. I think a lot of challenges for our nurse case managers that then are getting all these calls from families before we've had a chance to deal. And speaking of the devil, one of our nurse case managers, Virginia, has her hand up to ask a question.
Yeah, I thought I'd pitch in. Thank you for this presentation. It's very good. I just wanted to let you know from a nursing case management standpoint. So there's a lot of focus on, notes from physicians and that kind of stuff, which is very important. But from a nursing point of view, from a coordinator point of view, the amount of calls and the amount of questions and the amount of fear and anxiety since being able to have a better access has increased our workload like quite significantly, because families don't quite understand. And I do find, I don't know, and I know you kind of you mentioned it just briefly about there's no standard in terms of what is an expected time frame in order for us to be able to get back to them. But at the moment, because there isn't a standard, I think that there is an assumption that we need to act right away when it may not be, because the family's perspective, it has to be done right away. But from a medical point of view, it can wait a little bit. So trying to find that balance to support the family's anxiety, but also to be able to have time to make a proper plan. I find there's a big unbalance there, and I just wanted to know what your thoughts were on that.
Sorry, we were just trying to figure out. I think it's very true and super important. I think it's really hard because I agree, and I think that there's tons of like that fear and anxiety that can certainly come up, and the way that we interpret results and make a plan versus how a parent interprets results for their child is going to be very different. And I wonder how we can sort of try to ensure that we are getting patients to getting them to a point where they have better access or easier access to their information. And it's hard when the evidence from a patient side is certainly on the side of we should have access to our information as soon as it's available, without causing this increased burden. I'm not sure I have a great answer about how we're going to do that, or ways to do that. But I think it's really challenging, and I hear you that it's a real increased workload, especially for the case managers who are, the sort of point person for those. And I do wonder about whether or not there's a way, especially in those cases, if we can, if we still need those time delays and still need time to enact those plans, and whether, at least for the time being, if we can try to organize appointments and at least say, we've seen this report, we're going to talk about it. We know that this is happening, and we have a time frame, and this is going to be our appointment. Because I think from what I was reading, that a lot of the uncertainty and anxiety is just not knowing when we can actually connect with the healthcare provider or when the next appointment is. And that's such an important part of us being able to see the results first, because then we can make that plan and already alleviate the stress. But when we don't have it, it's impossible to do so. Yeah.
And I think it's an important something to consider too is sort of the shift in medicine as a whole from like a little bit more of a paternalistic view towards a more like who actually owns the information. Like, is it the patient that owns the information, like we saw in that Supreme Court from 1992, that the patient actually owns the physical information? So it's just a shift too of like, how do you balance between obviously wanting to do what's best for the patient, but also engaging them with their care?
I was just going to say to Virginia, I don't think actually this has ever been studied. So when you look at the literature that's available, it's interesting that they look at increased workload for the person who's writing the note. No one has looked at what is the increased workload for the individual who's actually receiving this communication. So just like a interesting area for future study that probably hasn't really been conducted before.
It would be nice to get a nursing perspective on this for sure.
Yeah, absolutely.
Yeah.
All right, thank you. There is one question in the chat from Marilena about for oncology who have experienced. We find we changed our practice as far as anticipated guidance when ordering tests. So we do provide that, but I will say honestly also, there is a way to block a result release in my chart, and maybe this is paternalistic, but if there's a relapse, often what we will do is block it and have the patient come to clinic the next day. So we can block when we receive, so it's not actually blocked before the patient would receive it, but we have them come so that we can have a discussion in person, which I 100% realize is a paternalistic way to do it, but we feel that that is better. And it's interesting, we have patient family representatives on our result release task force, and it's interesting because some oncology families are like, yeah, no, please don't release it, and some are, please release it. So it's interesting. But as Jim King put in the chat that there is a process looking right now at result release, and a large group of people looking at it. So this has been super helpful for many reasons. And I don't see any other questions, that we're 9:30 on the dot. So thank you all so much for a really, really informative, excellent talk. It was really, really great.
Jeff, go home to sleep.